I'm really glad that you've had several patients speak today. Incredibly powerful stories. The ones that I heard from, and I apologize if I missed any, but Trish, Caitlin, and Carl, those were all, very powerful stories and really get to the point of my talk, which is there's more that we need to understand about how we can help patients and how we can develop therapies that best meet their needs. I need to disclose that I'm a member of the Speakers Bureau for VOUST. And then here are a couple acronyms that I'll use throughout the talk. Several of them I'm sure you've heard before or even seen today, but just to clarify, RCDI is recurrent C. diff infection. And then we have post-infection irritable bowel syndrome. And ones that you may be less familiar with are PRO, which is patient-reported outcome, and then HR-QoL, health-related quality of life. So just a bit of background as to how I think most of the scientific community sees C. diff as affecting patients. The burden of this infection, it largely gets boiled down into a bunch of binary outcomes, one of which is hospitalization. And among all C. diff cases, this is data from the CDC's Emerging Infections Program from 2022, 41.8% of C. diff infections resulted in hospitalization. And this includes healthcare-associated and community-associated infections. Interestingly, now community-associated infections have actually outpaced healthcare-associated infections, which one highlights we have a lot of work to do to improve antimicrobial use and inappropriate antimicrobial use in the outpatient setting, but also that C. diff lives everywhere, and you don't need to be exposed to a healthcare system or a long-term care facility to be at risk. The rate of hospitalization can be as high as 85% among patients with recurrent C. diff infection. And there's been data published. I'm highlighting some data from Dr. Ravelis, one of my colleagues, and Dr. Gary was part of that paper as well, that showed C. diff patients versus non-infected controls were more likely to be discharged somewhere other than their home, such as a long-term care facility. So, the consequences of C. diff follow these patients after they've stopped their antibiotics or after they get discharged from the hospital. And that's also well highlighted by the fact that this disease is plagued by recurrence on recurrence. These are cumulative proportions of recurrence based on the data from registration trials. So from fidaxomicin, bezotoximab, and then the newer LBPs, Rubeola and VOUST. In patients that are presenting with their first C. diff infection or don't have a recent history of infection, the recurrence remains 19.8%. This is regardless of whether they received vancomycin or fidaxomicin. But once you get recurrent C. diff infection, the recurrence is as high as 38.7% and even beyond in certain cases. Then there's some more rare outcomes, even more rare outcomes, like ileus and toxic megacolon, which happen in 1.8 and 0.2% respectively. Post-infection IBS occurs in approximately 21% of patients, and that can persist for months following a C. diff diagnosis. So again, we have a lot of ways to quantify what the consequences of C. diff are for patients, but there are patients that don't experience any of these things, yet C. diff can be absolutely devastating to them. And that's where patient-reported outcomes comes in. So the problem is all of these things that I've shown are published on over and over and over again. They're widely reported. They're easy to obtain, which is probably why they exist. But they fail to capture the burden of CDI in those that don't experience some of these binary outcomes. Patient-reported outcomes allow researchers and clinicians to either qualitatively describe or quantitatively measure the effects of C. diff on patients. And that can be a one-time point, but most usefully, it can be following the patient after an intervention. So before and after an intervention to see how the patient has improved. And rather than relying on some binary outcomes, some of which are relatively uncommon, these can be used to document the spectrum of CDI in all patients, and we get an idea of their perspective in it too. It is kind of unfortunate, the fact that we identified C. diff as the causative agent for pseudomembranous colitis and C. difficile infection back in the 1970s, but we didn't start to really understand how it affected patients until 2010. And there were a couple early studies that had semi-structured interviews, but later on, we've started to develop and kind of reutilize healthcare-related quality of life tools to be able to quantify and describe patients' experiences with C. diff infection. And, you know, I'm not going to go through all of these, but one thing that you will notice is there's a few tools that have been used several times, the most common of which is the C. diff 32 score, which was initially developed by Kevin Gary and colleagues at the University of Houston, and has been validated several times, including in more recent clinical trials. So I want to highlight that just because it has been so commonly utilized. This is a survey that patients take. It's 32 items that exist across these three domains. The physical domain entails 14 questions, the mental domain includes 14 questions, and then social relationships has 4 questions associated with it. And patients are asked to answer on a 5-point Likert scale. Those scores are transformed from 0 being the worst quality of life all the way to 100 being the best quality of life. And they've found that during the validation process that a minimally important difference, meaning really the smallest change that you can reliably detect in a patient, is going to be 10 points from, for example, before and after an intervention. And this should be based on the patient's past 7 days. So in the past 7 days, how have they been feeling in terms of these 32 questions? It has been integrated into clinical trials, as I mentioned. So this was EcoSpore 3. And there's a couple ways that they illustrated the information. First of all, they included the total score as well as the scores from the 3 different domains. And here you'll see the C. diff 32 score in the patients who received VOWST versus those that received placebo. And for both the total score and the physical domain score, there were significant differences between the two. So this is looking at the graphic off to the left is looking at the score change from baseline to week 8. Another way to look at it would be to go back to that minimally important difference and look at the proportion of patients that experienced at least a 10-point increase from baseline to week 8. And same patients, same data, you can see that both the total score and the mental domain was significantly different between the VOWST and the placebo groups, although you will notice that there are numerically greater numbers of patients that experienced this 10-point increase in the VOWST group for all 3 domains. This is data from the Punch CD3 trial, and they did the assessment in the full population to the left, as well as a subgroup of patients. This subgroup were patients who had experienced only 1 prior episode of C. diff infection, so this was their first recurrence. And you will certainly see numeric differences between Rebiota and the placebo-treated patients. The significant differences in the overall clinical trial cohort was significant in the mental domain. And then in that subgroup of patients who this is their first recurrence, there were significant differences in total score as well as mental domain. Another interesting tool that is trying to do something different than the C. diff 32 score is called the CDI DaySims. And this is something that can be integrated into clinical trials that assesses a patient's symptoms across 3 domains: diarrhea symptoms, abdominal symptoms, and then systemic and other symptoms. Patients again answer these questions on a 5-point Likert scale, so 0 being no symptoms to 4 being very severe symptoms. They have validated it in a clinical trial and found the minimum important differences. And this is based on a 24-hour recall period. So this is something that you could utilize every day to see how the changes in symptoms are improving over time. So how are these tools used and how should they be used? Well, again, they're doing different things. It's both reliant on patient-reported outcomes. The CDI DaySym score can measure day-to-day differences in patient-reported symptoms, and for example, could measure symptoms at baseline and then when initial response is assessed, for example, at the end of antibiotic treatment in a clinical trial, whereas the CDIF-32 measures health-related quality of life over the past week. So it's a more long-term assessment, and it can measure this quality of life at baseline and then when sustained response is assessed, for example, 30 days after the completion of antibiotic treatment, or in the case of Ribauda and Vowst, it was performed at baseline and then again at 8 weeks after they received Vowst. Now, there's a lot of information on the gut microbiota-brain axis, but I just want to put it in the context of C. difficile infection and discuss a little bit more about, the concept that I briefly talked about the domains of the CDIF-32 score, but one big chunk of it is current anxiety and future anxiety. And there have certainly been associations between either the presence or absence of certain bacterial taxa and neuropsychiatric disorders, including anxiety and depression. Separately, antibiotic exposure has been associated with a new diagnosis of depression or anxiety. This isn't in the C. diff literature, just simply antibiotic exposure leads to or has been associated with these new diagnoses. And then in the C. diff literature, we've found that either a diagnosis of depression or the receipt of antidepressant or GABAergic medications have been associated with an increased risk of C. diff. So clearly there's a relationship between antibiotic use causes dysbiosis. Dysbiosis both increases the risk of a C. diff, but it also increases the risk of depression and anxiety. Then you have on top of that the anxiety and perhaps depression that goes along with just feeling really down and defeated by having recurrent C. diff over and over again and feeling like you can't win or feeling like you can't get the therapy you need. And sometimes it's hard to tease those things out. Nevertheless, I think it's important to recognize the fact that that is really going on in the background. So I think there are some opportunities for us as a scientific community, especially given that C. diff is kind of the prototypical microbiome disease. Whether or not anxiety and depression is mediated by dysbiosis, when you have somebody diagnosed with C. diff, you know they're at rock bottom. You know their microbiota is completely destroyed, and it's a perfect opportunity really to measure the long-term effects of a dysfunctional gut microbiota in terms of either the development or new diagnosis or even worsening of neuropsychiatric disorders. And perhaps we ought to be thinking of C. diff as a chronic disease, or at the very least a comorbidity that increases the risk of other diseases and conditions like depression and anxiety, and think about looking at health-related quality of life further out than just at 2 months, which is what has been done to this point. 2 months is great, and it's much more expensive to study further out than that. But if we can perhaps show that by giving some of these, microbiome restoration therapies, that we can show it not only prevents C. diff recurrence, but also prevents some of the neuropsychiatric symptoms that go along with C. diff infection, that would be pretty powerful. And so, documenting the proportion of patients who are taking medications for these diseases and disorders before their diagnosis, and then the number of patients who initiate either a new medication or get a new diagnosis, especially when you're able to control for things in an interventional trial, comparing something that's going to fix that dysbiosis versus placebo that's not going to fix those things. So I would urge clinicians to do what they can in either their own setting or trying to gather some information from observational data, but certainly from the pharmaceutical company when they're designing clinical trials, think about some of these things. Certainly with more and more of these microbiota-based therapies coming out, everyone is going to have to set themselves apart a little bit. And so perhaps we can start to tease out some of these really challenging relationships in the gut microbiota brain axis. And with that, I will take any questions if we have time.
Thank you so much for that presentation, Dr. Carlson. We might have a moment for a question or two if people have them. It is also a Friday afternoon, so people might be like, "Oh, my brain."
I totally understand that.
Oh, wait. We got Susan O'Brien. I always can count on Susan. She said she may have misheard. Is there a concern that certain mental health medications may increase C. diff risk? If so, which ones?
Yeah, Susan, that's a great question. So there have been associations between exposure to antidepressants, and various medication classes kind of fall within that larger category, but think SSRIs, SNRIs, tricyclic antidepressants, as well as GABAergic medications. And these are things like benzodiazepines, which are used to treat anxiety, as well as people take them for other things. And then even like gabapentin is a GABA active medication. So things that modulate these different neurotransmitters. Our gut is actually responsible for the production and homeostasis of a lot of these neurotransmitters, believe it or not. So there is a biologic basis for whether or not the dysbiosis is causing differences in neurotransmitters, or you're taking a medication that changes neurotransmitters. All of those things influence how our microbiota acts and what the overall health and function is like.
That's actually interesting because I'm on all of those medications as we speak. No, just a couple.
Well, and yeah, I mean, it's the challenging part is, I mean, this is observational data. We have associations, but and they've done animal studies to show, at least experimentally, that some of these things hold true. But it's not going to be the case for everybody taking these medications that you're going to get C. diff. And so we have a lot yet to learn, really, about who truly is at risk, what are all of the other things that factor into it, that type of thing.
Yeah, and I think, something that we talk about a lot here is that there are certain trade-offs. Like I know for a fact that proton pump inhibitors are a risk for C. diff, and I lost my mother to C. diff, and I'm constantly talking to people with C. diff. But my grandfather died of esophageal cancer. And the biggest risk factor for esophageal cancer is untreated GERD. So I'd rather not get cancer.
Absolutely. Everything is risk benefit. And we've heard from several patients that experience a lot of anxiety and maybe even going into depression, and to not treat that is significant as well. So again, it's not meant to scare or worry anybody that you shouldn't be treating these things, but just that there is there's a lot of complex stuff going on that we need to better understand, and using C. diff as the mechanism to do that might be a good idea.